create a dedicated forum for all of us to connect, to network, and to engage in shared learning and mutual support as we navigate the complex ethical landscape of military healthcare. And when we meet together, we believe we all can learn about what is occurring in the field, whether you're at Madigan Army Medical Center, Landstuhl in Germany, Tripler in Hawaii, and beyond. Collectively, we want to work to address the ethical tensions that arise from our diverse missions. So for those who may be less familiar, the DMEC is the implementation of the DoD Medical Ethics Program outlined in DoD Instruction 6025.27, which dates back to 2017. And this instruction established the requirement for a systemic and integrated program office. The instruction outlines responsibility for this office to the president of Uniformed Services University, more commonly known as SU, under the direction and control of the Assistant Secretary of War for Health Affairs, currently Dr. Ferreira. And this mandate is for this office to serve as the national and international lead for military medical ethics. Now, I want you to know that the DMEC is here for you as a resource, and we have developed a DMEC website as well as an app that provides resources for healthcare ethics with information and videos. And we do receive inquiries and requests for consultation by email. These requests are sent to Ms. Polly Combs. This information is on our website. She is the management and program analyst for the Griffith Institute and the DMEC. She is the invitee, that the person you got the invitation from today. Additionally, we maintain a contact list of subject matter experts to provide auxiliary consultation for healthcare professionals. So we've got outreach to folks with various levels of expertise. So the DMEC is your hub for ethics resources, regardless of where your duty station is. So now I'd like to make a quick note of the logistics of our virtual meeting. We would like to ensure this session's valuable content is accessible for those who cannot attend this meeting today. So the presentation of this meeting will be recorded, and we will endeavor to post that on the DMEC website so that you and others can access it for later review, or folks can access it again if they weren't able to attend today. However, we will stop recording before the open discussion period. And we would like to do this so that everyone feels comfortable sharing specific ethical experiences and asking questions without their comments or questions being permanently recorded. So please feel free to be open and candid during our live discussion. Before we start, I want to take a moment to specifically acknowledge the individuals who were instrumental in getting this community of interest started and advancing our mission. So a huge thank you to Lieutenant Colonel Dr. Jeannie Crick. She is the consultant to the Army Surgeon General for Medical Ethics. And a shout out to Colonel Dr. Catherine McHugh, who's the consultant to the Air Force Surgeon General for Medical Ethics. And as always, I'd like to recognize Ms. Polly Combs. She ensures all the necessary coordination and logistics are executed flawlessly. Her support is really more than administration. She's absolutely key to advancing the Griffith Institute and medical ethics missions. So to kick off our formal learning, I'm pleased to introduce Lieutenant Colonel Jeannie Crick, who will be presenting on the ethical analysis beyond the four principles. As you know, most ethical discussions begin with principalism, beneficence, non-maleficence, respect for autonomy, and justice. Dr. Crick's presentation will review these foundations, but more importantly, she will introduce us to robust methods for ethical analysis. The goal here is to broaden your analytical toolkit, giving you a more comprehensive framework for tackling the difficult clinical and leadership issues that land on you and on your committees. And so with that, I'd like to turn the floor over to Dr. Crick. Dr. Crick, over to you.
Thanks, Dr. Bader. I really appreciate it. I'm just going to try to share my presentation here really quickly. So during this, just so you know, I'm only working on one screen today, so I'm not going to be able to see the chat or see anything. So if you have a question, feel free to interrupt me. I really love this to be more interactive if you have questions. I also am fully admitting that this audience is one that's a lot higher level when it comes to an ethical analysis. A lot of you have served on ethics committees for a long time. I'm not trying to reteach you things that you already know. What I'm trying to do is share a method that I use, that I've used for several years since I went through my training with ethics, of how I analyze some of these really challenging cases. And my experience with giving this presentation or versions of it in the past has been it's been able to enhance folks' ability to look at some of these cases from a more theoretical lens. So that's my goal today. But to kick it off, I'm Jeannie Crick. I'm a neonatologist and the program director for the Neonatology Fellowship down here in San Antonio at Brooke Army Medical Center. As far as my ethics background, I did complete a clinical fellowship in bioethics as well as a master's degree in bioethics and humanities. And I've served as a consultant to the Surgeon General of the Army for medical ethics for the last 4.5 years, I believe. And I am also the chair of the ethics committee here at BAMC. So I'm just had an ethics consult this morning. So have done several consults throughout my time. All right. So to kick us off, what am I going to do today? So I'm going to go through some basic analysis process, something that you all are probably very familiar with, but just to state it out loud and get us all as a clinical community talking about the way that we do this, because there is not a standardized process. So I think it's important that we talk about this so that we are ensuring that we are providing a robust service to the clinicians around us and to family members and patients. I'm going to go through a quick review of principlism. That's probably the most accessible to everybody here and something that you all use. But then I'm going to dive a little bit into the different theoretical lenses that I use when I'm going into consults. Because very frequently what I hear is, oh, well, ethics is really, you balance out the principles and you don't really know this versus this one. And you just kind of reach a conclusion. That's not what I do. I use a lot of different theoretical lenses to analyze these cases. And this is how I reach a conclusion that I can give a recommendation to a team about. A couple of caveats up front. So I am not a philosopher. I don't pretend to be one. I am not at the level of the fine Dr. Walter who is on here. So if you really want to geek out, go talk to him about these different theories. And I'm not trying to make you an expert in philosophy. And maybe your role is not to provide bioethics consultations. And so I'm not trying to make you an expert in this. Neither could I in a 20-minute presentation. But really, like I talked about with the purpose, this is just to expose you to a little bit of behind the scenes with my mind, scary thing, of how I go about doing ethics consults. So let's start with a notional case. So we've got a 24-year-old female. She has anorexia nervosa, and she's admitted after a syncopal episode to the hospital. She has some laboratory findings, specifically hypokalemia, as well as hypotension that is preventing her from being discharged from the hospital. And the team is recommending nasogastric feeding, and she's refusing. And so you get a call as an ethics consultant saying, hey, we think that she needs this, and we really want to mandate this nasogastric tube feeding. So what do you do? So you may already have an answer in your head because, like I said, most of you are pretty experienced at this, but I want to go through with a case that may or may not be a little bit more simplistic, how I do this in a robust and methodologically sound way so that it's not just a knee-jerk reaction when I'm getting these calls. So the first thing to break apart is that I have what I call an approach, where my ethical approach is how I go into the case, how I go through the different steps, and then I have a framework. So my approach really starts with the 4 boxes. And I'm guessing that many of you are very familiar with the 4-box method. But for those of you who aren't, this is generally what it is. So the 4-box method is these 4 different boxes that talk about the information that is going to be relevant to how you conduct an ethical analysis of a case. So the first is medical indications. That's the one that's usually the most straightforward. What's the diagnosis? What's the prognosis? What are your goals of treatment? What are the probabilities of success of those different treatment options? Then you get into patient preferences. That goes nicely along with that and talks about the risk-benefit analysis of the patient themselves, not the medical team. The capacity judgment is a very big part of this. Stated preferences, if they are lacking capacity, what do we know about their prior preferences? Anything about a surrogate decision maker is in here. And then how are they cooperating with medical treatment? Because that underlies a little bit about these patient preferences. The next I move on to quality of life. And I get to what are their prospects to returning to a good quality of life? Who's judging that quality of life? Is it really the medical team making those judgments, or are we relying on the patient and their families? And who decides what an acceptable quality of life is and what that looks like? Then lastly, I go on to contextual features. That can include a lot of different things. I've listed a few here, but this is by no means all inclusive. And it really can take into account a lot of different factors that are incredibly relevant for these cases. So as I'm going into a case, I'm usually getting a phone call first. And the first thing that I'm doing with myself when I get a phone call is I'm drawing this box for myself and saying, okay, what are they telling me about these different pieces? Oftentimes, I'm going to get a clue to each one of these boxes, but I'm not getting the whole story. And that's where it's so important for me with a true ethics consult to go to the bedside, to talk to the patient, to talk to their surrogate, to talk to the different members of the medical team, because I may not quite understand who is judging the quality of life if I'm just hearing it from the medical team. I may be getting some biased looks at things. So it's so important for me to get that 360-degree view that I think is so relevant to our role as ethics consultants. So the next step with that is I'm asking questions. So I'm asking questions to really fill in that box to the best of those boxes to the best of my ability. But I'm also trying to now assemble things in a more cohesive manner for myself. So I'm really trying to get down. A lot of times, I'm sure a lot of you can relate. When I get these calls, it's like, okay, I understand you're feeling uncomfortable, but what's the issue here? What are you really asking me? What is the actual question that you're getting at? And sometimes that's the most challenging thing to do, is to understand what is the ethical question that they're asking. Oftentimes when I'm working with somebody and performing a consult with them, I will eventually get to a place where I'm proposing an ethical question. That's really what I aim to do at the end of any of my first conversations with somebody who's asking for a consult. And it oftentimes looks like the question looks something like, is it ethically permissible to XYZ? And so oftentimes I'm trying to get to a place where they can articulate what that ethical question is, because it's much easier to answer a question when you have one, as opposed to just giving a lot of different recommendations. So important to know the stakeholders. That's why when I have a true consult, I really try to get to the bedside and talk to the parties involved, because I think it's important that none of those voices are squashed in this process. And oftentimes there is a conflict, whether that's the medical team versus the patient and their families, or it's different members of the medical team, or maybe everybody's cohesive and it's everybody versus the disease process. But you really want to unpack those, because that will allow you to go into your more robust approach in analyzing these cases. So as you step into that ethical approach, that ethical analysis, the first step most of us are most comfortable with is applying the 4 principles of medical ethics: beneficence, non-maleficence, respect for autonomy, and justice. And this is largely what I see from most consultants. They'll say, okay, in this case, yeah, I'm concerned about the beneficence, non-maleficence weight versus the respect for autonomy. That's often where that conflict lies when we're talking about these different principles. And typically we can resolve that. But oftentimes that balance is really hard to resolve, just saying that there's a conflict and autonomy is going to win out. Well, maybe not, or maybe there's some sort of shades of that we need to unpack a little bit more. So what I always like to say with principlism is there's more than just that. So that's step one, as you're trying to call out where those tensions are, but how are you going to resolve those tensions? And that's what I really wanted to focus on today. So there's different uh, theoretical lenses that I use when I'm going to do these different analyses, and that's what I want to share with you. So we're going to talk a little bit about virtue ethics, care ethics, deontological ethics, casuistry, and utilitarian ethics. And again, I've got a slide each on these, not trying to make you an expert, nor do I claim to be an expert. I might get some of these phrased a little differently than you have heard them phrased before. And that is part of the challenge of doing this, and part of the reward of doing this is that I'm constantly learning. So with virtue ethics, the one that you classically hear this linked back to is Aristotle. It's emphasizing the virtues of the actors in question. So I'm talking about the virtues of sound mind, of a good character. What does it mean to be a good physician, good clinician, good nurse, good caretaker? And that sense of honesty, it's really what lives inside and what drives your motivations for actions. So when I'm trying to simplify something for myself, in a case, kind of a screening question I use for myself when I'm seeing, does virtue ethics play a role here, is there something that a virtuous agent, hospital system, whatever, would do in this situation? And maybe that's my trigger, that's where I need to go. So a sample case for me, this had more to do on the organizational ethics side, and I was not involved in this case, but it has to do with whistleblowing in healthcare. So many years ago, Seattle Children's Hospital had an outbreak of aspergillosis in their ORs. And there was a question of how much disclosure to release to the public, because obviously there was a concern of causing panic and leading to issues with trust in the local community. And when I reflect on this case, I think back to virtue ethics of, if I want to have trust in an organization and I want a trustworthy, virtuous organization, what would I expect them to do? I want them to have integrity. I want them to have compassion. I want them to have courageousness. And so in this case, I think it's so important that there's full disclosure of what's going on and full transparency in order to uphold those virtues that I find so important. So virtue ethics sometimes is challenging to apply in the bedside cases, unless we're talking about some very clear-cut items like honesty, transparency. But I think it does have a role definitely on the organizational ethics side. Care ethics. I'll be honest, this is one of my preferred lenses to go through, and it just it has more to do with my background than anything else. But a few proponents of this who have done quite a bit of work in this are Virginia Held, Carol Gilligan, and they really focus on one individual's position within relationships. So when you look at the principlism, the four principles, we talk about respect for autonomy a lot. And we oftentimes in Western medicine give supremacy to that principle. But what that lens is sometimes overlooking is the fact that we are all shaped by our relationships, and our relationships are influencing those decisions and are influencing our ability to make decisions in an autonomous way. And that's probably okay. I'm going to make decisions as a mom, as a wife, as a member of my family, as a member of my community. And oftentimes in medicine, we say, well, we don't want undue influence from this. We really want that autonomous person's decision in this. And maybe sometimes we overstep with that. So this is more of a check on myself when I'm worried about undue influence, or how this is affecting a family dynamic, or how a patient and their loved ones are making decisions together for something. This is often a lens that I go with. I should comment that one of the important relationships is between the medical team and the family, or the patient themselves. And so that's a big piece of this, of how do we preserve that relationship and make sure that it's upheld without all of this. So a sample way that I think about this case is, if you've got a family member who is taking care of, especially an elderly patient, they may ask for non-disclosure of medical information. So they may say, hey, my mom is 89. I take care of her. Yes, she has capacity, but she doesn't need to know that she has this terminal cancer. I think that will just kill her. And, she's really at the place in her life where she's comfortable with this and with me receiving the information. And I don't think you need to tell her everything. Now, of course, you don't want to just take that at face value. You want to establish that that is acceptable within that relationship, because we still want to preserve our relationship as the medical team to the individual patient. But maybe respecting that dynamic of the family is part of this. And so that's where this lens comes into play a lot for me. So the next one is deontologic. So Kantian ethics, this is a big one that I'm sure many of you are familiar with. And this really gets at rules, obligations, duties, where this is, how does my action adhere to a rule? This is a little different than when we were talking about virtue ethics. Remember, virtue ethics is more about like my character, my internal. This is more, how are my actions aligning with some rules, and how are my the way that I carry it out aligning with that. So if you go back to Kant, one of the big things that you'll discover is the categorical imperative. And what the categorical imperative says, that an action that I do should go in a way that whatever the maximum of my action is can become a universal law. So Kant would say that you should never lie, because if you lie once, then that is violating that categorical imperative, and that I can't do that just once, even if it's for good intentions, because I need to make sure that my action can become a universal law. I'm not sure my husband would agree with that when I ask him how I look in a dress, but hey, whatever. So a sample case, though, for me, where this does come into play, gets at that truth telling, like we were talking about before. When I've encountered cases like this where you have a family member who knows something about their own medical information and they don't want their family to know. We have an obligation to the patient in front of us, not necessarily the family, but we are also under no obligation to lie when we are asked questions. What we can say is that we can't disclose information. You should talk to your family member, but we don't have to lie and go along with the lie that the family supplied and wants their family members to think. So if a family member doesn't want to donate organs and they're saying, "Oh, can you just tell my loved ones that I'm not a match," even though you know they're a match, you are under no obligation to do so. So this is where that comes into play for me. Casuistry, and I can never pronounce this one correctly, so forgive me if I'm mispronouncing it. So this is where we use a paradigm case to look at the similarities and differences and apply it to a current case. So this is like case law when we're talking about analogies there. So if you know that there are several cases that have been borne out prior that follow a similar script, you can probably extract some of the same ethical analysis from that case moving forward. So I say a sample case here because this is very much in my wheelhouse. You've got an 8-week-old former 26-weeker who parents are refusing an eye exam. Well, I've encountered that several times in my career and walked through many of these ethical analyses. So I can rely a lot upon that prior case to know how to bring that forward. And so we really need to ask ourselves, though, before we just blanket say, "Oh, this is done before." No, no, no. We have to really dig in. Is it similar? Is it different? What do we know about that underlying that? And then lastly, utilitarian ethics. Jerry Bentham, John Stuart Mill are two that come to mind. There's plenty more. Consequentialism is a bigger overarching field of ethics when we talk about utilitarian ethics. And this really focuses on the outcomes of our actions. So, what action is going to produce the greatest good, happiness, however you define that? And that's where the definition of that is slightly different depending on which philosopher that you align with. But this often gets applied in times of resource allocation. So, how am I going to take these scarce resources and come up with a system that uses them in order to produce the greatest good for the greatest number? We can all think of many sample cases. The pandemic was a huge time where utilitarian ethics had a massive role. And we've seen that more recently with the IV fluid shortages. And now, as we are going into some supply shortages with the government shutdown, we're certainly seeing some of this. Okay, so now that I've walked through that, how do I actually do this? So this was a worksheet that one of my instructors in my master's program developed, and she knows I use this in this talk. But I find it really helpful because it makes me stop and think about all these things. So, establishing up front, who are the stakeholders? What are their values? What's going on? Who are the players? Then it gets to those 4 boxes that we talked about at the very beginning. And then you finally get to that ethics question. Like I said, that's oftentimes the hardest thing to do is to come up with the actual question. Then, as I get over to the right-hand side, I actually like to start from the bottom and work up. And that's what she recommends to do as well. Can I talk about a little bit of the consequences, the virtues, the rules, meaning deontology, those social relationships, that care ethics? How can I examine this from those different lenses, and how can I bring that together to come up with an answer to that question? Is it ethically permissible to XYZ? And so now when I'm saying why it's ethically permissible, now I'm using some of the things from those different lenses as I'm providing that justification. And then finally, I'm getting to the recommendation for the clinician. And that's where you really want to simplify it and give them, a few, yes, it is ethically permissible because of this. And these are the steps you need to take to ensure that it stays ethically permissible. But the reason that I wanted to share this with you all today is that so often I get concerns from bedside providers that, well, I'm not going to call ethics because they're just going to wax poetically about how it's the contrast between, autonomy versus beneficence, non-maleficence. And ultimately, at the end of the day, they're not going to give me the answer I want anyway. So why the heck should I call them? This is where I really see our value is in providing them not only with these diverse perspectives and an extra extra tool to be able to bring out those different voices, but also to give them the robust backing of like, this is why I'm coming to this recommendation for you. So we went through that. I'm not going to go into the practice case today because I see that I'm a little bit further along time wise than I had expected. But at any point in time, I encourage you to put some of these into play. Feel free to reach out to myself at any point in time. I'm easy to find and global. And thank you again for your time today.